Esophageal varices is the topic, and esophageal varices are essentially the dilated veins that exist in the distal esophagus. So you've got these dilated veins that are in the distal part of the esophagus, and what can happen is that they can rupture, and if they rupture, they can cause an episode of massive bleeding. Now, there's an elevated pressure in the portal venous system, and that's why these veins are dilated. Now, why does this happen? What's the cause? The most common cause of dilation in those veins leading to esophageal varices is liver cirrhosis. And in particular, most of the clinical vignettes involve alcoholism. Now, the portal pressure rises, and eventually what happens is these veins in the esophagus start to become engorged and serpentine-like. And they exist in the submucosa of the esophagus. And of course they're given a special name, and that special name is known as varices. And because they're in the distal esophagus, esophageal varices. Now what happens is, if the pressure is greater than a certain amount, these varices can rupture. So when the pressure gradient gets really high, greater than 12, the varices can rupture. And when that happens, you have essentially caused massive bleeding. And it's actually pretty dramatic when a patient presents to emergency room. So, what are the symptoms? Well, apart from the history of a person who's an alcoholic with known liver cirrhosis, basically you have an episode of massive upper GI bleeding. Now, I wanted to quickly mention that clinical vignettes will sometimes try to trick you by putting in massive bleeding or some other terms, but in the answer choices they'll have another option known as Mallory-Weiss tears. And you might wonder, what's the difference between Mallory-Weiss tears and this topic, esophageal varices? Because both occur in alcoholics and both cause upper GI bleeding. Well, the difference is that both of them can cause upper GI bleeding, of course, but esophageal varices will cause a more dramatic and impressive episode of upper GI bleeding. So, usually, the esophageal varices have massive bleeding, whereas the Mallory-Weiss tears, because they are just small tears in the esophagus, the bleeding is not as dramatic. So that's how you can think about it. So how do you diagnose this? Well, by far, the main way to do it is an EGD, esophagogastroduodenoscopy. Big long word. Essentially it means, for those of you who don't know, it's a tube that you put down the esophagus that has a camera, and it takes a look at what's going on inside. Now, in addition to the EGDs, do some simple blood tests, CBC. Obviously, if there's any type of bleeding, I always want to check the CBC. PT, PTT, these are bleeding-related tests. Liver function tests to check person is most likely a person with alcoholic liver cirrhosis. Now, how do you treat it? Well, there's two things that are done. The first is a medication that's given IV. It's known as octreotide. And what octreotide does is it decreases the blood flow. And in addition, what happens is there's an inhibition. It inhibits the vasodilation. So these are contributory factors. Vasodilation is, of course, a contributory factor to the fact that there was bleeding in the first place. So that's a very important medication given IV. The next thing that's done is something known as endoscopic banding. And what this means is that essentially while you're doing the EGD, at the same time, what you do is you put a rubber band around the enlarged veins. And what that does is essentially cuts off the blood supply or blood flow and helps to control this condition. Now, if a person continues to bleed or has recurrent bleeding, or if there's an emergency situation, you do a procedure known as TIPS. And TIPS stands for transjugular intrahepatic portosystemic shunting. Now what this means is that this is a procedure that is done to create a bypass between the portal and hepatic venous circulations. Now, what this does is it essentially relieves the portal hypertension, and that helps to decrease blood flow. So, that is the TIPS procedure. So now let's look at some clinical vignettes. A 45-year-old man who is admitted to the hospital for alcohol detox develops bloody emesis on day 3. Over the past hour, there has been approximately 500 cc's of bloody emesis. Patient has history of alcoholism and hepatitis C. Vitals are temperature is 38, blood pressure is 100, pulse is 122, respirations are 9. Patient is oriented and answers questions normally. Physical exam reveals a thin, jaundiced man in a mildly lethargic state. He has mild ascites, caput medusa, and lower extremity edema. Most urgent clinical issue that should be addressed is, well, this is a classic scenario with the patient with a history of alcoholism and hepatitis C. Both are risk factors for cirrhosis of liver. And he's definitely presenting with a pretty good amount of hematemesis, which is vomiting blood. And without a doubt, the most urgent clinical issue is the fact that he's got esophageal varices, and that those varices have ruptured and causing this bloody vomit. So that would be E. The next question. 58-year-old homeless man is brought to the emergency department with severe hematemesis. He has a history significant for severe alcohol abuse and significant esophageal varices with bleeding in the past. You notice in his old chart that it was recommended that he take a multivitamin, folate, and thiamine. Blood pressure is 100, pulse is 105, respiratory rate is 26. Physical exam shows coarse breath sounds and a protuberant abdomen. Nasogastric lavage yields fresh blood. Given that you strongly suspect another varicose bleed, the most appropriate next step in the management of this patient is? Well, they've mentioned all these medications, and you have to figure out which one. Well, the medication that's given IV is a medication that decreases blood flow. And in addition to decreasing blood flow, it also inhibits vasodilation. And of the ones listed, the one that does both of those things is octreotide. And then finally, 47-year-old man comes to the office for follow-up management of his ascites and cirrhosis. He has been your patient for 3 years. He has known hepatitis B and alcohol-induced cirrhosis. He takes furosemide and spironolactone daily. 6 weeks ago, he underwent an upper GI endoscopy that showed grade 3 esophageal varices. You're interested in offering him therapy to prevent a possible devastating upper GI bleed. The most appropriate management to prevent bleeding is 2. Well, one thing I immediately noticed is you come to your office, so this is not an emergent situation. You have to sort of discuss it with him. So the TIPS procedure is probably not going to be the most appropriate management right now. TIPS procedure is done usually in emergency situations to relieve portal hypertension, and that decreases the risk of bleeding. But if he's relatively stable right now, probably want to offer something different. Of those, the most appropriate recommendation would be this banding, where you would put essentially a rubber band around the varices, and that will allow you essentially to prevent them from rupturing. And that essentially is the first line treatment, other than the octreotide, which was mentioned in the previous question. The rubber bands that are placed around these enlarged veins help to cut off the blood flow and help prevent the devastating upper GI bleed that you are most likely worried about him developing. So that would be choice D.